Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Thank you very much for the GIS organizing committee to invite me to present. And I wish I was there, but we can present the case from here. I was asked to present a dissection case, and it took me a long time to find one, mainly because of coronary stents that we take care of dissections very quickly, but we will go through this case. Okay, so can you see my screen? The organizer says we can. Okay, so it's a 78-year-old man with unstable angina, a creatinine clearance of 28, good ejection fraction, three-vessel disease with syntax score 2 of 42, mortality 18%. The surgeons refused the patient for cabbage, and the family did not want cabbage either, so we decided to go for PCI for this patient. So this patient obviously has a CTO of the right coronary artery. It's a long CTO. This is the diagnostic film. And he had significant disease in the LAD as well as the circumflex. And the entire right is filling here. So that's what gave him his syntax 2 score of 42 and mortality of 18%. As another picture, and it's important to look at the left main here, the circumflex, and the right coronary artery, and the LAD. So this was my plan. I think we always have great plans, and we have to have good plans. To do ultra-low contrast, IVUS-guided PCI of the LAD and circ, and then RCA PCI guided, of course, with intravascular ultrasound. So I will not spend much time. Circumflex was fixed, the LAD was fixed, and basically with 35 cc's, not very ultra low, but with 35 cc's of contrast, I was able to do the LAD and the circumflex. And then we went after the right coronary. I will not spend time on CTO because this is not a CTO session. Antegrade access was not very successful. So I went retrograde, and retrograde just went easy, and we did all the maneuvers for externalization. That's not important. And that's it, and I was done. I was able to externalize the wire, the two wires met, and so 90% success when retro wire passes, right? Externalized, I confirmed no damage to retro channels. I injected the septal collaterals, which was fine. The retro wire removed, and we started with pre-dilatation of the right coronary artery with IVUS, stent, and IVUS. And then the patient crashed. I don't have drama like Dr. Awad's. The patient did not say anything important or he just crashed. And we actually started CPR with levofed, adrenaline. We called for help. We have excellent cardiac anesthesia. They came in. We have excellent interventional cardiologists with me. They came in. And obviously went through the thing. Is it a perforation, tamponade? Is it septal rupture, hematoma? Is it vascular bleeding? Echo, we have an echo machine in the cath lab that came immediately. No tamponade, absolutely no bleeding. The septal collateral is fine. And this is the donor vessel. And obviously this is while we're doing CPR, and you can see the heart is not really moving much. Actually, one of our techs noticed something. He said, this left main doesn't look normal. And let's look at that. See this white shadow in the distal left main extending into the LAD across the circumflex. And that was the only clue I had that this is a dissection of the donor left main LAD. So that immediately took care of it. We had the safety wire, so immediately stented it, ballooned it. We had the IVUS on the table. All that was fixed. And that took care of this vessel, and the patient's hemodynamics improved. And we were able to complete the RCA CTO, which was almost done by that time. So dissections are rare. And most of the dissections we see now are guide-induced. You have Dr. Mohanad, and everybody has mentioned they're mainly guide-induced. Radial guide-induced dissections are more common, both for the right and the left, because with the radial artery, there is a lot more moving with the diaphragm. And I think that is one of the reasons, plus the guides may not be as stable radially, because these are femoral design guides. And what you really need to have is access to the distal vessel. And the worst thing that can happen is the loss of wire position or spiral dissection with almost no distal vessel. This is a slide I just took from the CTO New York meeting from February 23rd, and give credit to Dr. Catherine Dawson. So if you have a patient like my patient with hemodynamic collapse, you have to have an algorithm and go through that. Is it ischemia? Is it bleeding? Is it respiratory problem, rhythm problem, cardiac reserve problem? Very common, but people don't mention it, is severe AI due to the Amplatz guides that can press into the aortic valve. Or is it anaphylaxis? And that we have seen it a lot, and hydrocortisone does miracles. So, and in ischemia, is it guide damping, thrombosis, air, no flow, or possibility with problems with the equipment? Of course, we think of bleeding first, which is both perforation in the coronaries, small vessels, large vessels, collaterals, or vascular access. So you have to go through that, and it is tough, and you have to think of these things, but it is kind of difficult when people are running around, there's a CPR going on, to be going through this. So this is important now. An algorithmic plan for complications, and you have to go through a systemic checklist for causes and remedies. Your team has to be tuned in. I have seen other hospitals where team members, I'll show you my phone, while there is a complex PCI going on, and the radiographer is watching YouTube on his phone. So the team members have to be focused in. You have to have support of cardiac anesthesia or critical care, ICU. You cannot have a cath lab in the outpatient department and the cardiac CCU and anesthesia in another building. So those things are important. And you have to debrief your team and yourself. Why did this happen? Well, I know there is no left main disease. This patient had IVUS done twice. When I did the LAD and the circumflex, we went through the left main, there was no disease there. So it was most likely a guide-induced injury during retrograde externalization that we did not pay attention to, because while we're doing the retrograde externalization, the antegrade guide can get sucked in to the donor vessel, and that may have happened and we didn't notice it. So what was good? Well, the good thing was we had the safety wire in the LAD, and this is an absolute yes, and Muhammad is ma'ana. During CTO PCIs, you have to do everything step by step. There is no shortcuts. You have to have a safety wire in the donor vessels. And what really, really helped me in this case was the donor vessel I had just treated with stents in the LAD and the circumflex. So this prevented the left main dissection going down the LAD and going down the circumflex and shutting down the entire thing. And that we had to recognize and treat it. And I credit my team for noticing that dissection before I did. And so what can I do better next time? Well, I have to be more cognizant of the donor vessel and more cognizant of my antegrade guide management. I've seen now people placing a safety wire in the aorta, a second wire, to prevent the guide getting sucked in. I'm not sure if everybody's doing that, but that's definitely something to do. And the other thing to do is important is we have so many quality measures and things that we do in the cath lab or in the hospital for whether it's JCI and different credentialing. We all know race and pass for fire. So if there is a fire, we have to go through race and pass. And how many people actually go through drills for complications in the cath lab? So you have to have your team train on drills for these exact things. So you don't have 4 nurses running around all doing the same thing. They have to have roles, and we have to have systemic algorithm that we have to go through. So what happens exactly like the fire hazard or chemical hazard, which we have to pass because the hospital has to pass credentials for JCI or something like that. So these things are very important, and your team has to go through these things maybe every 6 months or every few months. So they are cognizant of going through these algorithms. So if there is a hemodynamic collapse, You have to go through these things very systematically, 1, 2, 3, 4, 5, 6, and take care of the patients. The patient did very well after that and is doing extremely well asymptomatically. Thank you.
Amazing.